When a child gets sick, especially with something like diarrhea or vomiting, their small bodies can lose fluids very quickly. This loss of water and essential salts, like sodium and potassium, is what we call dehydration. It might sound simple, but for a child, it can become a serious medical emergency in a surprisingly short amount of time. Think of the body as a finely tuned machine that needs water to run every single one of its systems, from the brain thinking to the heart beating. When that water level drops too low, these critical functions can start to slow down and, in the worst cases, fail completely, putting the child's life at risk. This is a scenario I've seen play out far too many times in clinics around the world. A young child, maybe just a toddler, is brought in by worried parents. They've had a stomach bug for a day or two. At first, it seemed manageable, but now the child is listless, not playing, and not wanting to drink anything. What parents might not realize is that the danger isn't just the illness itself, but the rapid dehydration it causes. Children are not just small adults. Their bodies have a higher percentage of water and a faster metabolism, making them uniquely vulnerable to fluid loss. This is why recognizing the early warning signs is not just helpful, it's life-saving. Understanding the severity of dehydration is the first and most critical step in managing a sick child. Is this a mild case that can be managed at home with simple fluids, or is it a more severe situation that requires immediate medical intervention? Making this distinction quickly and accurately is paramount. A delay of just a few hours can be the difference between a quick recovery and a prolonged hospital stay, or even worse. This is where a standardized, easy-to-use tool becomes incredibly important for healthcare workers on the front lines, whether they are in a state-of-the-art hospital or a remote village clinic. That's precisely why the Integrated Management of Neonatal and Childhood Illness, or IMNCI strategy, was developed. It provides a clear, systematic approach for healthcare providers to classify a child's condition. For dehydration, the IMNCI guidelines offer a simple yet powerful framework to categorize the severity into one of three levels. Media group, nurse categorizing dehydration severity on medical form, doctors showing IMNCI dehydration levels chart, stock or distribute equally, no dehydration, some dehydration, or severe dehydration. This classification isn't just an academic exercise, it directly guides the treatment plan, ensuring that every child receives the exact level of care they need at that very moment. It empowers healthcare workers to make confident, life-saving decisions under pressure. The IMNCI classification for dehydration is built on a simple principle: look, feel, and ask. It doesn't require complex lab tests or expensive equipment. Instead, it relies on a set of key clinical signs that any trained health worker can observe. The process begins the moment the child enters the clinic. The first step is to assess the child's general condition. Is the child alert and active? Or are they lethargic, restless, or even unconscious? A child's level of consciousness and irritability can be one of the most telling indicators of how severely they are affected by fluid loss. It's a window into how their brain is functioning. Next, the health worker will look at the child's eyes. Are they normal, or do they appear sunken? When the body loses a significant amount of fluid, the fatty tissue behind the eyeballs also loses water and shrinks, causing the eyes to recede into their sockets. This is a classic and reliable sign of dehydration. Imagine a young boy named Leo who has been vomiting all night. His mother notices that his usually bright, round eyes now look tired and hollow. This is a visible clue that his body is in distress and needs fluids urgently. It's a sign that parents too can learn to spot at home. After observing the eyes, the health worker will offer the child some water or an oral rehydration solution. The key here is to watch how the child drinks. Is the child able to drink normally, or are they thirsty and drinking eagerly, almost desperately? A child who guzzles down the fluid is clearly trying to compensate for significant fluid loss. On the other hand, a child who is too weak or lethargic to drink, or drinks very poorly, is in a much more dangerous state. This simple test of thirst provides a direct insight into the body's internal demand for water, a crucial piece of the puzzle for the health worker. The final physical check is the skin pinch test, also known as checking for skin turgor. The health worker gently pinches a fold of skin on the child's abdomen for 1 second and then releases it. In a well-hydrated child, the skin will snap back into place immediately. However, if the child is dehydrated, the skin loses its elasticity and will go back slowly, or in severe cases, very slowly, taking more than 2 seconds. This delayed reaction is a direct measure of the fluid content within the skin tissues. These 4 signs, general condition, eyes, thirst, and skin pinch, form the foundation of the IMNCI assessment, painting a clear picture of the child's hydration status. The IMNCI framework uses the signs we've discussed to classify dehydration into 3 distinct categories. The first and most favorable category is no dehydration. A child in this group will not have enough signs to be classified as having some or severe dehydration. They are generally well and alert. Their eyes are not sunken. When offered a drink, they drink normally, not thirstily. And when the health worker performs the skin pinch test, the skin goes back quickly. This is the child who might have had 1 or 2 episodes of diarrhea, but is otherwise playing and behaving as usual. Their body is keeping up with the fluid loss. The next level is some dehydration. This is the most common category seen in clinics and requires prompt action. A child is classified with some dehydration if they show 2 or more of the following signs. Media group, restless or irritable child in clinic, close-up of child with sunken eyes, thirsty child drinking eagerly from cup, healthcare worker performing slow return skin pinch test on chilled stock, distribute, equally. They are restless or irritable, their eyes are sunken, they drink eagerly because they are thirsty, and their skin pinch goes back slowly. Let's picture a 3-year-old girl named Maya. Her mother says she has had watery diarrhea 5 times today. When you see her, she is fussy and constantly crying. Her eyes look a little hollow, and when you offer her a cup of oral rehydration solution, she grabs it and drinks it down quickly. These signs together clearly point to some dehydration. The most critical category is severe dehydration. This is a medical emergency that demands immediate and aggressive treatment. A child falls into this category if they display 2 or more of the following danger signs. Media group, lethargic or unconscious child in hospital bed, healthcare provider checking unresponsive pediatric patient, close-up of child with deeply sunken eyes, nurse performing slow skin pinch test on severely ill child stock, distribute equally. They are lethargic or even unconscious. They are unable to drink or drink poorly, and their skin pinch goes back very slowly, longer than 2 seconds. Sunken eyes are also a key sign here. Imagine an infant who has had severe diarrhea and vomiting. They are lying limp in their mother's arms, barely responsive. Their eyes are deeply sunken, and when you try to give them a drink, they are too weak to swallow. This child's life is in immediate danger. It's crucial to understand that these classifications are not just labels, they are action plans. A child with no dehydration is managed differently from a child with some dehydration, and a child with severe dehydration requires a completely different level of care. For example, a child like Maya with some dehydration can usually be treated at the clinic with a specific amount of oral rehydration solution over a few hours. But the lethargic infant with severe dehydration needs intravenous fluids immediately to restore fluid volume directly into their bloodstream. This clear 3-tiered system ensures that resources are used appropriately and that the most critical patients receive the urgent care they need to survive. Once a child's dehydration level is classified, the IMNCI guidelines provide a clear path forward, known as treatment plans A, B, and C. For a child with no dehydration, the advice is treatment plan A, which is all about home management. The goal here is prevention, to stop dehydration from developing. Caregivers are instructed to give more fluids than usual. This means continuing breastfeeding, but more frequently, and for older children, offering oral rehydration solution, soups, rice water, or yogurt drinks after every loose stool. It's also vital to continue feeding the child to give them the strength to fight the infection. Parents are taught the signs of worsening dehydration and told to return immediately if they appear. For a child with some dehydration, we move to treatment plan B. This is a supervised treatment that usually takes place at the health facility. The child is given a specific amount of oral rehydration solution over a 4-hour period. The amount is calculated based on the child's weight. The health worker will show the mother how to give the oral rehydration solution, small, frequent sips from a cup. The child is reassessed after 4 hours. If the signs of dehydration are gone, they can switch to Plan A and go home. If the signs are still present, Plan B is repeated. This plan is about actively rehydrating the child under a watchful eye. When a child presents with severe dehydration, it is a life-threatening emergency requiring treatment Plan C. This plan calls for urgent hospitalization and intravenous fluid therapy. Oral fluids are not enough because the child is either too weak to drink or the fluid loss is too massive for oral rehydration to catch up. An intravenous line is started immediately, and fluids are given rapidly to restore circulation and organ function. Once the child is stable and can drink, oral rehydration solution is started while the intravenous continues. This aggressive approach is necessary to pull the child back from the brink and prevent irreversible organ damage or death. Ultimately, the power of the IMNCI classification lies in its simplicity and direct link to action. It empowers health workers at all levels to assess a child quickly, classify their condition accurately, and begin the correct treatment without delay. For parents and caregivers, understanding these principles is just as important. Knowing how to prevent dehydration at home and recognizing the warning signs that mean you need to seek help immediately can save your child's life. Early detection and the right action at the right time are our most effective weapons against this common and dangerous threat